Hi, interns. Welcome to your beginning steps of starting your residency and making growth as a future physician. I really wish I could be with you today, but unfortunately, patients have loaded up the clinic. So I thought I would just record this so that I can share some ideas about clinical thinking with you, as it's a concept that's near and dear to my heart. And I really feel like no matter who you are, what flavor of physician you're going to be, if you master this skill, being an excellent clinical thinker and diagnostician, you're going to be way ahead for the rest of your career. So with that being said, let's go ahead and dive into a process of how to think clinically using a Bayesian approach. So most people natively use type 1 thinking, and you guys have probably seen something like this before. Somebody presents with a syndrome, you recognize it, and because you've seen that pattern before, boom, you move right to your diagnosis and you're ready to start treating the patient. And when that happens, that's really elegant, it's very timely, it's super efficient, but there are problems with type 1 thinking. So take, for example, this snake. So this is a copperhead. They're in the area. Welcome to Joplin. And they are poisonous, but not that bad for humans, so don't run away. But here's the thing. Here are at least 8 different snakes that are commonly mistaken for copperheads. So there are similarities between the actual copperhead and these other snakes, which, a lot of these are very benign, non-poisonous snakes that make it very confusing to always know for sure what kind of snake that you're staring at. And unfortunately, diseases can be a lot like that as well. So in clinical thinking, everything starts with a complaint, or, I'm not really a big fan of the word complaint, but they present with a symptom, and that's where we start using our techniques. So for example, here's Sharon, as she's a 70-year-old Caucasian female. She complains of stabbing, severe left flank pain. Her history, she's had the pain for about 2 days. She's peeing some blood. She's had some nausea with the pain. However, she's not having fevers, and she's not having any complaints of weight loss. So here's something that probably not too many of us have really stopped to think about. How many symptoms can a human being actually complain about? You would think it could be a lot, but that's where I think it's very surprising that when you start to think about like all of the symptoms that a human being can manifest, there's a real finite pile. So what I did, I went to the ICD-10 and I started pulling all of the symptoms that ICD-10 has collated for us. And I counted them all up, and there was about 184 symptoms. And if you think about it, you only have so many parts. Those parts can only manifest certain problems, and so there's a finite amount of symptoms, right? Headache, itchiness, gassy, burpy, chest pain, pressure, I see blood where I shouldn't. There's only so many symptoms. But here's the thing. Let's round that up. Let's say, okay, McNabb, there's 200 symptoms that a human being could complain about. Well, how many diseases are there? Well, it's a debate. It depends upon how you categorize these things. There's somewhere between 13,000 and 30,000 distinct disease states on the books. That's a lot. It's certainly way more diseases than we have symptoms. And that's the problem with type 1 thinking. So in my very odd way of thinking about this, I really think about the symptoms like colors on an artist's palette. You've got pain, you've got fever, you've got the nausea color, you've got rash, you've got these disease colors, these symptoms, and you have to share them to make every disease. And so, when you see all these beautiful paintings that I put up here for you, they're all using paints off the same color spectrum, right? But how you mix and match them, how you weigh out how much of those colors you lean into and where you place them, you can produce very different images using very similar colors. And that's the way diseases are too. We have a finite number of symptoms, and they're all being shared by a very large amount of diseases. And that's where this job gets a little bit tougher than you would think. So let's just take the symptom fever, right? So look at all these diseases, and this is a very brief and incomplete list, right? You could have all of these infections, right, of which there are many types. There's bacterial, there's viral, there's parasitic infections, fungal infections, mycobacterial infections. But a fever doesn't have to be associated with an infection. It could be an autoimmune problem. Maybe lupus is just ravaging your patient. Or maybe your patient has cancer or leukemia. Or it could be a metabolic problem like hyperthyroidism. Or it could be a drug fever or a DVT. My point is even with something as common as fever, the differential, all the diseases that share that one symptom are broad. We paint with pain and fever all the time. You're going to see those symptoms show up constantly. And so we need to have a well thought out process and what to do with these symptoms. So we need type 2 thinking, which is differential driven. There's a syndrome. Do you recognize that syndrome? Maybe yes, maybe no. Well, I need to have a differential diagnosis because think about that copperhead. Yeah, I think I do know what's wrong with Sharon. She's peeing blood and she has flank pain. I've seen that category of problems before, but now I know that there are other things that could overlap with that. So I really need a differential diagnosis if I'm going to be as accurate out of the gate as I can be. So in my estimation, if you want to be a high quality, safe physician, you have got to dedicate yourself to having a differential diagnosis. I stole this quote and altered it from the Principles and Practice of Hospital Medicine. It's a pretty good text. A clinician's ability to successfully reason and diagnose is, and I scratched out all that stuff, is anchored by the clinician's ability to create an adequate differential diagnosis. It's not optional. We have to have it, and we have to have it every time. So if you think about your differential diagnosis, it's kind of a list, potential list of antagonistics. Who done it, right? Could be any of these 5 bad actors. And so this is the way that I think about my differential diagnosis. I think about it like a net. I need to get my arms and my brain around what actually is wrong with my patient, and I need to capture that diagnosis quickly. The quicker I know what I'm dealing with, the quicker I initiate the correct therapies, the quicker the patient has a chance to recover. But if you think about a differential diagnosis like a net, size probably has its pros and cons, right? Like, for example, on the right side with the little goldfish scooper, if you've ever tried to scoop up a fish with a little scooper, man, I don't know that I've ever been successful with that. It's really difficult. If your little scooper is so small, the chances of you actually catching the diagnosis quickly is pretty slim. So maybe I need a really big net. Well, that's certainly going to help you capture the right differential, but there can be a downside to that too. If your differential is too big, you can capture a lot of potential diseases, and that may make you inefficient. So it really is about trying to have not the biggest or the smallest differential, but having something that's reasonable and appropriate and clinically useful for you. So you don't want to be extravagant with every differential known to man, but you want to have enough to be accurate. So this is what I think a reasonable differential diagnosis for Sharon would look like. So she comes in with flank pain and hematuria, so maybe she's got pyelonephritis. I've certainly seen people with hemorrhagic cystitis. So yeah, that makes sense. Bladder infections, kidney stones, very common. Renal infarction, not as common, but it's certainly possible. Renal cancer, I've absolutely made a diagnosis of renal cell carcinoma probably 30, 40 times in my career. And then bladder cancer. There's always the possibility of bladder cancer. Now, there's probably other things that you could add in here, but I think this is reasonable. So let's narrow that down just for simplicity's sake. And let's say that our differential is infection, so UTI pyelo, could be kidney stone, could be renal cancer. Well, one of the first things that you should probably think about is how prevalent is this disease process. So, UTIs are very common. 1 in 4 people are going to have a UTI. Kidney stones are very common. 1 in about 11 people are fated to have a kidney stone at some point or other. Renal cell cancer, very, very rare. 15 out of 100,000 population. So if every time you see somebody who has flank pain and is pee in blood, you immediately say, this must be renal cell carcinoma. Well, you're going to swing and miss a lot because just statistically, the deck's stacked against you, right? So I think that that's a good way for us to start thinking about how am I going to stack my differential? How do I order it in a list of most likelies to least likelies? Well, some of these things should be useful for you, right? Like prevalence or epidemiology. So Sharon, she's a woman. UTIs are more common in women than men, but not exclusive. Kidney stones are more common in men than women, but not exclusive. And renal cell cancer does weigh towards men. And then there's ages. She's older. Anybody can have a UTI at any age, but definitely the older population is higher risk. Kidney stones tend to be more younger and older people, or middle-aged people, I should say. And then, of course, like every other cancer on the planet, statistically, the older you get, the more likely cancer becomes the possibility, right? Other things to consider. Time course. UTIs and kidney stones tend to have a pretty abrupt, pretty quick crescendoing presentation, whereas renal cells, like a mugger, just kind of creeps up on you over time until you can't ignore it. When you look at those symptoms, we know that the hematuria and the pain can be common across all of those. So does fever, more associated with UTI, if you think that, maybe that sways you. I've certainly seen lots of people with renal cell carcinoma that had fevers too. We used to call renal cell carcinoma or nephromas the great masquerader because it can have a lot of symptoms that are confusing and make you think of a lot of other things, right? So picking through the symptoms to figure out where maybe there are unique things to just that one diagnosis that maybe that would help sway you. Those are things you want to look for, not the commonalities, but the things that are unique to each diagnosis. And then, of course, you need to be aware of the testing. How do I test for each one of these things? And how am I going to weaponize my tools to be able to help me make my accurate diagnosis? So we're going to use a Bayesian approach, or that's my recommendation to you guys. The first thing that you do in a Bayesian approach is you need to set your prior confidence. So this means you need to order your differential from most likely to least likely. And then what you want to do is evaluate all the data that you've collected to that point. So whatever they did in ER or whatever came with the patient to the hospital. And you need to ask yourself, does the amount of data that you have make you more or less confident in the diagnosis that you think is probably the thing? Then the next question is this. Do you already have enough evidence that you're satisfied that you know what's wrong? If you feel like you know what's wrong with the patient, then do I need diagnostic testing or do I just treat the patient, right? But if you recognize that you haven't reached that threshold of confidence, then you need to ask yourself, well, what do I need to get to that level of confidence at which I'm going to pull the trigger and start treating the patient? And then that makes things really easy. What do I need to show myself to say, yep, I've got this in the bag. I know what this is. I'm ready to treat. We'll just do that one thing, right? And then here's another human being question, kind of leads into a concept of heuristics, or anchoring heuristics for sure. Are you willing to change your priors? If nothing I show you in the patient's CAT scans or laboratories is going to budge your thoughts on what the diagnosis is, then what's the point of looking at it? And why wouldn't you consider outside information? If those things lead in a different direction, why are you closing your mind to those things? An anchoring heuristic is a very powerful thing that human beings do all the time. As clinicians, we have got to be on guard against these sorts of thought fallacies. All right, so clinical reasoning kind of looks like this. We're going to gather some data. We're going to organize and interpret that data. We're going to make a hypothesis. Based on what I'm seeing in these patterns, I think the problem is this. I'm going to test that hypothesis, and if I feel like I reached a conclusion, I'm going to interact with that. I'm going to start treating things. So let's take a look at Sharon. So 70-year-old Caucasian female. Okay, so she's 70, so she's older. So I think that makes her higher risk to have a UTI, and probably, old enough to have cancer for sure. She's a woman, so more likely to have a UTI. I don't know. I've seen a lot of 70-year-old men who have UTIs due to BPH, right? Uh, okay, we'll look at our medical history. Oh, that's interesting. She has this history of hyperparathyroidism. So, would that make her more likely to have stones? That makes sense. I mean, if it's not treated, or I would have to learn more about that. Was she surgically treated? Is she in remission? Is it just something that they're watching? I don't know, but maybe that's a clue that should be shifting my prior confidence, right? Well, she's also diabetic, and diabetics, they get a lot of infections, so maybe she's at a higher risk to have pyelo or cystitis because of the diabetes. She's also on high blood pressure. Very common high blood pressure medicines, HCTZ, that raises your calcium. Would that make her at a higher risk for a stone? I don't know. Something to think about, though. Oh, wait a minute. Look at her family history. Her dad had renal cell carcinoma. Now, I know you're thinking, well, yeah, but Dr. McNabb, you said it's like 15 people in 100,000 population. So, boy, I put that on the very bottom of my differential. Well, she has a first-degree relative who had renal cell carcinoma. Does that change your pretest probabilities? Does that change how you stack that deck? You're going to have to think about these things. Okay, well, she looks pretty stable. She does not really run in a fever. She's a little tacky. She's a little bumped in her blood pressure, but nothing there really seems specific or diagnostic to me. And here's her physical exam. She's got this left flank tenderness to touch. I don't see trauma or bruising to make me think that there's a musculoskeletal issue here. Abdominal exam, no mass is felt. So, but how would you trust your own physical exam on a somebody with a BMI greater than 30 and say, yeah, I didn't feel anything in the abdomen. There's probably not a mass. I'm not sure about that. Okay. So when you think about your prior confidences, we've got this differential of three things: infection, kidney stone, renal cell cancer. We need to first put that into a list of probabilities, right? And so I've kind of stacked this: UTI greater than stone, greater than cancer, and we could argue about would you switch that order for any reason or not. Here's how I put it. I'm kind of a statistics nerd, so common things happen commonly. I tend to use those thought processes. So what we're going to do is we're going to ask ourselves about our prior confidence. So I think, maybe it's a UTI, right? Okay. All right, McNabb. Do I feel confident enough to just give her the antibiotics and send her home? or do I not? So when I'm starting to think about those things, I need to think about it in three piles. There's the above 80%. I'm just going to treat it. I know what this is. There's the below 30% confidence where that's so low probability. I'm probably just going to like take it off my differential. I'm like, yeah, I mean, it could be, but I think it's so low probability. I'm just not even going to ponder it. So those are easy. But then there's this big middle pile, that 30% to 70, 80%, where you're like, it's possible, maybe it's probable, but has it reached a level of competence? Have I reached a level of competence that now I've made a decision, right? Well, you guys are going to spend a lot of your time in this middle zone of, I think, but I'm not really sure yet. I'm not confident enough to pull the trigger. So, okay, so when you recognize I have my prior confidences, but I've not reached my threshold where I'm going to make a commitment, well, this is where testing lives, right? You need to ask yourself, what do you need to reach a level of confidence? So, I got a urinalysis. Well, let's take a look at it. Okay, well, 3 plus blood, a lot of blood, but no white blood cells and no bacteria. All right, McNabb. Uh, so, you said common things happen commonly in UTI. We put that at the top of our differential. Uh, does this make me more confident that, yeah, you're a genius. This is exactly right. Or would this decrease your confidence? Well, I'm looking at this and thinking, well, if I'm thinking UTI, I need to see pus. I need to see bacteria. Now, you may not always, and there are certainly cases of people having non-communicating pyelo in an infected cyst. So, it's not a slam dunk here. But, I mean, I would have thought if this lady was having hemorrhagic cystitis or pyelo, she would at least have the decency to give me some white blood cells or 100,000 colony forming units or something. So that seems less likely that infection is going to be my thing. Well, okay, but she got all this blood. Does that increase my probability that renal cell cancer or stone are more likely? Yeah, I would say probably. I don't think it helps me understand which of those things it is. So where I'm thinking about UTI, my pre-test probability has now gone down. I'm thinking probably not that. I'm going to chuck that thing. Now I have it down to a differential of two things. It's the stone or it's the cancer, and I don't feel confident that I can just say it's one or the other. I'm going to need more testing for that. So in my mind, what I need is this your CAT scan? Okay. So I got this CAT scan thinking it could be a stone or it could be cancer. Our dad had that renal cell cancer. So I'm looking at these kidneys, and the parenchyma of both kidneys looks pretty dang normal to me. I don't see exophytic masses. I don't see an abscess for that matter. The kidneys look pretty normal in character, uh, with two exceptions. One is you can see the kidney on my right is swollen. It's got some hydronephrosis. You can see that compared to the other guy. And it has a big old honking UPJ stone clogging up the works. And they even have a tiny little stone kind of stuck in the parenchyma of the kidney itself. So, okay, so I've got this CAT scan. Do I need to continue to worry about renal cell cancer? Probably not. It seems very unlikely that that's the issue here, and seems pretty likely at this point that Sharon is trying to pass a big old stone, and that explains why she has the flank pain, and that's why she has the hematuria. That thought process makes great sense to me, and I've ruled out the other important things in my mind. So now I'm ready to commit to whatever treatment that we think a person with a kidney stone needs. So see, we boosted up, we used the least amount of tests to get us to a level of confidence that we are ready to interact with that disease process and treat. Yay us. So because there are so many symptoms, or I guess I should say only so many symptoms, and because they're widely shared across many disease processes, we're unlikely to ever be 100% sure that our patient does or doesn't have a particular disease. It just doesn't work that way. You're always going to be practicing with probably at least a moderate to high degree of uncertainty on your way to figuring out what's wrong with your patient. So using a Bayesian approach and type 2 clinical thinking, all based around what do you think is a legit differential diagnosis that you're willing to interact with, and be honest with yourself about your confidence levels in what the evidence is showing you, is going to help you become the most accurate, the most effective clinician that you can be. And of course, if you don't think about it, you ain't going to treat it. And if you're shooting at the wrong diagnosis, then you're not treating the patient's real problem. So we need to really make ourselves engage with this process and just use it until it becomes ingrained as your habit for being a clinical thinker. And if you do that, you and your patients are going to be much better off because of it, guys. So if you have any questions about Bayesian thinking or pretest probabilities or clinical thought process or differentials, where to find tools to help you with that, reach out and let me know. I'm always here to help you. I always want to be a resource for you guys. Now get out there and make some good diagnoses. If I see you, I'm 100% going to ask you about your differential diagnosis and your pretest confidences and where are you in that spectrum. So be prepared just in case you have to call me on any of my patients, or if I just randomly see you in the hospital, you never know. With all that, get out there and enjoy your internship and go save some lives.